Hello everyone. Today we are going to talk about management of crossbites. Learning outcomes for this lecture will be the student should be able to define what are crossbites, identify the etiology of crossbites and classify the various types of crossbites, and finally to formulate the treatment plan for management of crossbites. Now, what is a crossbite? Now, crossbite is basically a discrepancy in the buccolingual relationship of the upper and lower teeth. Now, as we know in the normal occlusion, the upper teeth slightly overlaps the lower teeth buccally. So here again in the you can see in this diagram in the posterior segments, the upper teeth are slightly placed buccal to the lower posterior teeth. Now, the crossbites can be classified first based on etiology. So, in this, based on etiology, we have three types of crossbite. One is the skeletal crossbite, dental crossbites, and the functional crossbite. Now, you can also classify crossbites based on where the crossbite is located. Okay, now if can be either be a anterior crossbite or it can be a posterior crossbite. Now, the anterior crossbite may have a forward displacement or may not have a forward displacement. Now, the posterior crossbites can be divided into buccal crossbites and lingual crossbites. The both are further subdivided into unilateral and bilateral, and the unilateral ones are further subdivided whether with displacement or without displacement. Now, the prevalence of crossbites is about 8 to 16%, 8 to 16%, and the prevalence of the single tooth crossbite is more than a unilateral, and which is more than a bilateral crossbite. Now, dental crossbite. A dental crossbite is a crossbite which is confined to the dentitions, wherein the jaws are normal in size and shape. A skeletal crossbite is caused by the malformation or malposition of the jaws. Now, this is commonly due to either a small maxillary retrognatism, or mandibular prognathism, or it can be a combination of both. Sometimes asymmetry in the transverse plane known as lateronectism can also give rise to a crossbite. Now, functional crossbite. The functional crossbite are caused by occlusal interferences leading to mandibular displacement to achieve maximum intercuspation. Now, the anterior displacement of the mandible causes anterior crossbite, also known as a pseudo class 3 relationship. Now, lateral displacement of the mandible causes a unilateral posterior crossbite. Anterior crossbites. This is when the lower anterior teeth overlaps the upper anterior teeth. It can be a single tooth or it may involve a segment of a tooth. If a segment of a tooth is involved, it's also known as a reverse overjet. Now, there may or may not be a forward mandibular displacement associated with the crossbite. Now, posterior crossbites are abnormal transverse relationship or abnormal widths between the upper and lower posterior teeth. Again, it may involve a single tooth as we see in this diagram, or it can involve a segment of teeth. Now, it may be unilateral or bilateral. In this diagram here, we see what is a unilateral crossbite involving only one side. Now, posterior crossbites can be either be buccal or lingual, now according to the position of the lower teeth. So in this diagram, the lower teeth is positioned more buccal to the upper posterior teeth. So therefore this is known as a buccal crossbite. Now there is another way of naming the crossbite, and this is to uh, to define it according to which arch is positioned lingually. So therefore under this way of definition, there are two types of posterior crossbite. Either it can be a maxillary lingual crossbite, as in this situation here, or it can be a mandibular lingual crossbite. So in this scheme, you define which jaw or which arch, the upper or lower, lies lingually. Oh, let's look at posterior crossbites. Now posterior crossbites can come with when it's unilateral, it may come with a displacement. Now this arises when the mandible is displaced laterally due to occlusal interference. Now a narrow maxilla results in a cusp to cusp relationship, and when this happens, the mandible shifts to one side to get into a position of maximum intercuspation and giving rise to a crossbite on one side. Now you can also get a unilateral posterior buccal crossbite without displacement. This commonly arises due to displacement of a single tooth or displacement of more teeth due to a skeletal asymmetry. Now, bilateral posterior buccal crossbites, this usually results from severe skeletal discrepancy, usually happens associated with class 3 relationship, and this is due to a narrow maxilla or a wide mandible or a combination of both. Now, you also have a situation known as a buccal nonocclusion. Now this is a very severe skeletal discrepancy, and commonly happens with severe class 3 skeletal pattern. Now here there is a narrow maxilla and wide, may be due to a narrow maxilla or a wide mandible or a combination, and it is known as a non-occlusion because the occlusal surfaces of the teeth are totally not in occlusion. Now the posterior lingual crossbite. Now when we say lingual crossbite, we are referring to the position of the lower teeth which is placed more lingually than normal in relationship to the upper. Now we get a situation called lingual non-occlusion, as we can see here. Now this is the reverse of the buccal non-occlusion. Lingual non-occlusion is also known as a scissor bite, whereby the palatal cusp of the upper buccal teeth in occlusion lies buccal to the buccal cusp of the lower posterior teeth. Now this is usually due to severe skeletal class 2 due to a retrognathing mandible. Now unilateral lingual crossbite, here again is caused by a skeletal discrepancy, okay, a narrow mandible or a wide maxilla or combination of both. It may be also due to displacement of teeth. Now little small quiz, okay, if B represents a normal relationship, how would you define A? Is it a buccal crossbite or a lingual crossbite? And what about C, which is buccal, which is lingual? Food for thought. Okay, Let's have a look at the etiology of dental crossbites. Dental crossbites, meaning they are due to the dentition, is generally caused by a number of factors such as crowding, anomalies in teeth in number, size, and shape like supernumerary, macrodontia, premature loss or prolonged retention of primary teeth. This can cause crossbites because of drifting of the teeth that occurs. Now, occlusal interferences and premature contacts can also cause crossbites. Okay, now if we look at the premature contact as in this diagram, now this age to age or cusp to cusp relationship is not a harmonious relationship, so therefore the mandible will shift to get into a position of maximum intercuspation, giving rise to a crossbite. Now, etiology of skeletal crossbites generally is due to discrepancy in the size of the dental arches, occurs with class 2 or class 3, and it can be due to habits such as digit sucking and mouth breathing. Cleft in lip and palate results in a severely underdeveloped maxilla, collapsed dental arches, giving rise to a crossbite. Now, TMJ trauma or pathology. A blow to the mandible, as in this diagram, can cause damage to the growth center in the condyle, giving rise to a underdeveloped mandible and leading to the development of a crossbite. Cheek pressure against the tongue pressure. Now, this causes a constriction of the upper arch leading to a posterior crossbite. Now, when the child is been sucking the thumb or digit for a long time, callus will tend to form on the thumb. Now, how do you manage digit sucking? Now, first, parents have got to be involved in the cessation of habit. Parents should encourage to stop the habit using a reward system. You should praise the child, importantly, don't nag, or could use a habit reversal therapy. Now, you can also use a reminder therapy, something like a finger bandage, finger pain, or boxing gloves, or a thermoplastic finger pose to discourage the child from sucking. You could even use a guard put on the elbow joint, okay, so that the child cannot bend the arm comfortably enough to bring the thumb into a sucking position. We could also use a adult habit breaker appliance. Okay, this functions as a reminder, but the child must want to stop the habit, and the appliance should be pain free and should not give rise to occlusal interference. Now, functional crossbites. In the deciduous and mixed dentition, premature contact can happen between the deciduous canines, which leads to lateral mandibular displacement. Grinding the canine tips, remember only the enamel, to eliminate the premature contact will eliminate the displacement and thus prevent the development of a crossbite. Now, treatment of crossbites. Now, crossbites, especially functional crossbites with mandibular displacement, should be corrected as soon as diagnosed. Now, if left untreated, it may develop into a severe skeletal discrepancy. For example, a pseudo class 3, if left untreated, will become an established class 3 eventually. Now, anterior crossbites. Anterior crossbites cause development of class 3 malocclusion if associated with forward displacement of lower incisors. Now, the proclination of the lower incisors seen in these anterior crossbites leads to periodontal damage such as fenestration and dehiscence of the labial plate, gingival recession, and eventually periodontal breakdown. Now, how do we correct dental anterior crossbites? Now, we could use simplest is to use a tongue blade therapy, whereby a wooden tongue blade is placed behind the tooth, erupting in crossbite. Patient bites on the tongue using the lower teeth as a fulcrum, and this is done for about 5 to 10 minutes. Another way is to use a Catalan's appliance. This is actually basically a lower anterior inclined plane, and it's cemented to the lower incisors. Now, for it to be successful, sufficient space must be available in the upper arch for alignment of the crossbite tooth. Uh, Caution is required, as prolonged use of this appliance may cause an open bite. Now, removable appliances can also be used. These can be various designs are available. This can be a Z spring or double cantilever spring to correct a single tooth in crossbite, as we see in this diagram here. You can have a cranked cantilever spring. We can have a recurved Z spring to correct more than one tooth in crossbite, or we could use an expansion screw for one or more teeth. Now, this is a cross cantilever springs, and this is an example of a expansion screw to correct the crossbite involving 4 teeth. Now, fixed appliances can also be used, whereby if bodily or apical movement of the tooth is required. Okay, success of any crossbite correction will depend on the presence of adequate overbite post correction. If overbite is not adequate, then the crossbite correction can relapse. Okay, correction of skeletal anterior crossbites. Now, in the growing patient, we can use a myofunctional appliances to correct this. We can use a reverse face mask, either with or without a rapid maxillary expander. And chin cup can be used for situations where the crossbite is caused by mandibular prognathism, and Frankel function regulator 3 can be used for class 3 malocclusion. This is a Frankel 3 FR3 appliance. Now, in the adult patient where there is no growth potential, a mild to moderate cases can be treated with fixed appliances with or without extractions. Now, severe cases will need surgical correction. The maxillary and surgical correction involves maxillary advancement and or mandibular setback, or a combination of both. Now, correction of posterior crossbites. Now, this can be achieved by the expansion of the whole arch or segment of an arch. Now, it's important to consider the inclination of the teeth. Now, the correction will be more stable if initially the teeth to be moved is inclined palatally. Now, if you compare these two diagrams, it's easier to correct or expand the arch in this situation because the teeth is inclined lingually. Now, in this situation, it's little bit more difficult to correct the expand the arch, as the teeth are already buccally tilted. Tilting the teeth more buccally will result in periodontal damage such as dehiscence and fenestrations of the buccal plate of bone. Now, correction of single tooth posterior crossbites. Now, we can do an extraction of the tooth in crossbites. This is usually applicable where the case needs extractions to be done. We could use a removable appliances to correct the crossbites. This is usually done using a T-spring, or we could use a expansion screw. Now with fixed appliances in conjunction with cross elastics, it can also be done to correct the crossbite. Now correction of lingual crossbites or scissor bite. Now one option is to accept the crossbite, because these crossbites are very difficult to treat. It can be treated with fixed appliances using temporary anchorage devices, TADs. Now appliances for the buccal crossbite correction. Now usually this involves expansion or increasing the width of the dental arch. The two broad modalities of expansion, one is a dental expansion, or also known as dentoalveolar expansion. Now the rate of expansion is slow. Now the second modality is the skeletal expansion. Now this aims for an orthopedic effect. It splits the mid-palatine suture, resulting through skeletal change. And the example of such appliances are rapid mandibular expansion appliances such as Hyrax, Isaacson and Hess. Now dental expansion or slow maxillary expansion appliances, you can use a removable appliance with a screw. A removable appliance can be used with a mini, medium or 3D screws. It can be used to move single tooth or segmental teeth, to move them labially. Patient cooperation is needed with the removable appliances, and you will need frequent visits to activate the screw. Now another way is to use a removable appliance with a coffin spring. Now the coffin spring consists of a omega shaped wire, as we see in this diagram. This is the omega shaped wire. Now it can produce bilateral symmetrical expansion, and it can be very simply activated by just pulling the two parts apart. Now a quad helix appliance can also be used. It can be either be fixed or removable. The fixed quad helix appliance is soldered to the bands on the first molars, whereas the removable quad helix is removable because it is not soldered but is inserted into a sheath on the lingual side of the molar bands. Now it can be activated. It has two anterior and two posterior helices. It can be activated manually by pulling apart the arms of the quad helix, or it can be adjusted using a 3-prong plier. Now a quad helix is able to produce differential expansion, meaning you can get different expansion levels in the premolar and molar regions. Now the next group of appliances are fixed appliances. Now the fixed appliances can be used with cross elastics. It can be used to correct a single tooth or a segment of teeth. Now the elastics are stretched from the palatal surface of the upper teeth to the buccal surface of the lower teeth. Now skeletal expansion or rapid maxillary expansion appliances. Now essentially this is a dentofacial orthopedic appliances, and the forces acting on the mid-palatal suture are transmitted via the teeth. Now these appliances usually consist of an expansion screw, and the framework is supported by the teeth, in which case is known as tooth bond. It can be supported by teeth and soft tissue, which is tooth tissue bond. It can be supported by teeth and bone, which is tooth bone bond, or it can be supported entirely by bone only, which is bone bond. Now activation is done by a turning screw which is given to the parent. Now the screw and key are self-limiting, will stop after one turn, and one turn is equivalent to a quarter of revolution of the screw, which means is equivalent to 0.25 millimeter expansion. Now 1 to 2 activations per day is done for up to about 3 weeks. Now after that, the appliance is left passive for 3 months to allow bony infill. Now once this is over, it is the expansion is retained either with a Holly retainer or a transpalatal arch. Now the problems with the skeletal expansion is it may give rise to pain and discomfort during activation. A diastema appears between the central incisors and the bone separates. Now the expansion is usually overdone to compensate for any relapse. Now an example of the rabbit maxillary expansion appliance is the Hyrax appliance. This is a tooth-borne appliance. The screw is directly soldered to bands on the posterior teeth, or it can be incorporated into a acrylic cemented onto the teeth. So this is known as the cemented type of Hyrax, and this is known as the bonded type of Hyrax. Now the next RME appliance is known as the Hess appliance. Now this one, if you look at the diagram, is got an acrylic pad which sits on the palatal vault. So therefore it is a tooth tissue bond appliance. Otherwise is similar to the Hyrax. Okay. Now we also have what is known as a mini screw assisted rapid palatal expander, or known by its acronym MAP. Okay, now this is a bone bond appliance. That means it is supported entirely by the bone. It is supported by temporary anchorage devices, TADs, or the other term is mini screws. So as you can see on this diagram, these are the mini screws that have been placed on the maxillary vault. Okay, and it has acrylic pads bonded to the framework which will push against the palatal vault. Okay, now we can also have a hybrid RME, okay, which is both a tooth and bone supported device. As we can see here, it also makes use of mini screws. Here the appliance, the conventional Hyrax is cemented first, and it has got two of these holes for placement of the mini screws, and in this second diagram you can see the mini screws in position. So therefore it is supported both by the teeth as well as the bone. Now what are the advantages of hybrid RME and MAP? Now because these are bone supported and not so much less supported on teeth, there's less dental tipping. Okay, usually when it is tooth supported, you will get a certain amount of dental tipping where the posterior teeth tips buccally. So now this it's best to avoid this tipping of teeth, because tipping of teeth will tend to cause periodontal damage such as dehiscence and fenestration. Now the surgically assisted rapid palatal expansion. Now this is a modality for older skeletally mature patients where it is difficult to separate the mid palatal suture. So in this procedure, it involves surgically splitting the mid-palatine suture, and also as well as combined with the LEFO1 osteotomy, and after which it is followed by a rapid maxillary expansion. Now, this surgical assisted RME is more stable than the conventional RME. Okay, these are the references for this lecture. Thank you.